one. Please start, so we are live.
All right, friends, this is an unusual week because we are having back-to-back. We had said normally we will have once a month, but last week the three experts deliberated on the TB diagnosis, which is, I think, very important at a very great length, including we showing the videos. So we overshot the time as was expected. So we had broken the things into two. Diagnostics is over on 11, that is last Thursday, and today we are back here for the therapeutic. And before I start this session, I think I will, of course, you know all the experts. We have the Guru of Guru, Dr. Varinder Singh from Lady Hardy Medical College, the director, and he's the one who has been pushing TB diagnosis, treatment protocols, as well as the national guidelines. And I think he's done some absolutely human services. So he's like our IIP Bharat Ratna for TB. So the second, of course, Dr. Sushant Mane, for people who are from Maharashtra and Mumbai, to very well know his help while managing patients of TB who are really difficult to manage. And every Tuesday, he actually has a session on difficult to manage TB patients. So some of you are really interested can join those sessions. But he is the in charge of the TB program there, and he's again one of the very resourceful and key person in the protocols which are made for TB diagnosis management, and himself gives human services at JJ Hospital. Last but not the least is my friend Dr. Vijay Yevle. He's an ID specialist, director of Yevle Hospital, and also the head of pediatrics at Apollo hospitals at Navi Mumbai. And again, with these two other experts, he has been instrumental in making the NTEP module on TB. And again, reiterate for those who haven't read it or undergone training in NTP module, please do it at the earliest, either self-learning or in one of the experts program, because that really will open up your vistas as to how you should approach a child with TB and how to manage. So with that brief introduction, I will first hand over mic to Nitin Jain. He's a business head for Zydus Vaxicare. And Nitin, over to you. So Zydus, of course, provides us this web stream platform for this monthly programs.
Thank you. Thank you so much, sir. Good evening, everyone. It's wonderful to be part of this scientific extravaganza. We've been talking about the tremendous success of this webinar series, which has started once again, and I'm sure it's going to reach out to more number of people, and the archives are going to be viewed by many. At Zydus, we continue to be committed to be partner in the scientific programs. While this entire program is dedicated for the different topics, I would just want to divert for a minute and not take more than that. That's the time allotted to me to talk about our efforts to improve immunization rate in India, because as we all know that in India the immunization adoption is less than 8%. Not many people get vaccinated, and that's where we reached out to 1,000 families which were between a group of 25 to 45 years with one or two kids. And when we did a detailed third-party research with them, we realized that India conventionally follow the grandparents' advice for the vaccination, and typically everybody reaches out to the pediatrician, and most of these things are followed up for 2 years. But in their own way, these families, 1,000 families, narrated the journey for them, that from entry, getting a file, going to a pediatrician, looking at the protocol board, was all about children and up to 2 years. And when we reached, we asked them that how do you get everybody in the family vaccinated? The answer was that we trust three people, that is physician, gynecologist, because the women of the home are going to, and the last is pediatrician, and for vaccination we'll trust them as well. And that is the kind of the equity we have in India. Having said that, we got a one beautiful insight that if India has to really achieve some distance in vaccines and vaccination rate improvement, probably it has to start from all of us together, because every baby comes with two adults, at least parents, and that's where we are strongly working with all of you to ensure that we start increasing immunization rate. Wouldn't talk much. Thank you so much once again for making us part of the scientific extravaganza. We are extremely happy for that, and we look forward for a long-term association. So thank you once again from Zydus Vaxicare.
Thank you, Nitin. We have galaxy of invitees who are joined on the Zoom link, and we have a lot of delegates who are on the web stream platform. So I will request Dr. Ramesh Bajania. All of you know him well. He has been running those Gujarat Pediatrician WhatsApp group, for last more than 10 years now, and I am also associated with these groups and doing CMEs before even the Zoom platform was known to ever to anyone, in the form of WhatsApp webinar, then from there to webinars, and today we are back to the third episode for this year. So Dr. Ramesh Bajania, you may please introduce the guest of honor, and then we will take forward the science.
Yes. Good evening, Nitin bhai. Good evening, all dignitaries. Today, we have got Dr. Simi Paulos, who is a current president of Kerala Pediatric Association. Sir, we welcome you to this today's academic program.
Little louder,
And,
Ramesh bhai.
Yeah. So, Simi sir, please have few words.
Good evening, everybody. Thank you, Dr. Ramesh sir. Especially being on this platform along with Varinder sir, Vijay Veli sir, and Dr. Sushant, and especially with Nitin sir. He was with us in IIP Kerala last Friday, for one of our sessions on regarding academics itself. So
Yes.
the session of TB consensus and confusions. I think so. This session was held last week itself, and it was one day prior to our session. So many
Right.
people missed out on Dr. Nitin Shah because on Thursdays we have an PG teaching program. So people couldn't get in at the same time to see this one. Thanks to Ramesh sir for having sent in the clipping, and we could share it with everybody and get information. So definitely hearing it out from the mastros on TB, especially listening to Varinder sir and Yavali sir, and also to Dr. Sushant on how TB is to be managed. Though we now try to push it off all to the government side, but there are things I think so, like how Nitin sir said, we have to really have a go through and start looking after things the right way, since we are trying to eradicate TB from our zone. So wishing the program all the best, and thank you for the invite. Thank you very much. Over to you all.
Thank you so much. Thank you so much, Dr. Simi. Now, Nitin bhai,
Yes.
with your permission, I'll start. Vijay sir.
Yeah, please.
During our residence,
Ramesh bhai, just before that, three things I want to, before we start the actual
please.
questions on treatment, what we've learned last week, because there might be some people who have joined new today. We said last time that the pulmonary TB in children is the commonest form of TB. Of course, there are other extrapulmonary forms which are sort of evident. You have a lymph node TB, you biopsy it, you get to know. You have CNS manifestation, you have neurotuberculosis, you get to know. You have abdominal TB, has diarrhea, pain in abdomen, lump, etc. You get to know. But the pulmonary TB is the one which is the most baffling, and that's where Dr. Yevle started by saying the triad of clinical manifestation of unremitting documented fever, unremitting and persistent cough, and with or without weight loss or no weight gain in spite of the best treatment in a malnourished child, and maybe a TB contact, which may be as old as 2 years since the time this patient has come to you, because Dr. Varinder very clearly explained us that people who can get reactivation or can transmit a disease knowingly or unknowingly, it can be even up to 2 years. So that's the reason why the cutoff of 2 years is taken. And in such patients, you don't start, they do a mantus and start him on treatment as we used to do so far. Mantus has hardly any role to play because the original mantu is not available. IGRA is there, but it doesn't differentiate between an infection and a disease. So it's okay to do IGRA in a patient, like say going abroad, where the university in US wants to know whether this person is tuberculized or no, but it doesn't really help you to manage TB in a child who is symptomatology. So you would do an X-ray first, and Dr. Varinder beautifully showed X-ray which are very likely to be looking like TB, an X-ray which may not be like TB but still may rouse suspicion. In any case, in those where there is no direct evidence on X-ray of TB, you treat them with antibiotic course for 8 to 10 days and then repeat an X-ray. And if it clear, then that's the end of the story. If the X-ray doesn't clear, or if the X-ray is suggestive of TB, then you will want to have a bacteriological diagnosis. So you can do either a gastric lavage or a sputum or an induced sputum depending upon the age of the patient, and send it for CBNAT or gene expert for TB. If it comes positive, look for R resistance. If it's resistant, then it's a different ball game. We'll see how to manage them. If resistance is not seen, then it is a sensitive TB, and you can start this patient on the frontline TB medicine. But remember to prove it not only for rifampicin but also INH, because mono INH resistance is to the tune of 15 to 20%. And if it is MDR-TB, like if R resistance, then you have to do the first line LPA and the second line LPA whenever either the sputum is strongly positive for AFB or you grow AFB on the culture. And those will tell you about the additional resistance to fluoroquinolone, to the second line injectables, etc. And of course, at the end, you will await the full phenotypic DST in a MDR patient and choose the best drugs which are available. And we will discuss those drugs as to how to treat them. That is the crux of the matter. Last time we had shown you the induced sputum video. So with the permission of Dr. Varinder Singh and other faculty, if you allow, we may show the video on the gastric lavage because I think that also was very beautiful. So if you can allow me to share my screen, I will show that. And then Dr. Bajania, we will take the questions for the TB management.
Yes, sir.
So, 1 minute. Share and this is the gastric lavage. You're able to see?
Yes, sir. Volume, sir. Voice is not heard.
Sir, click on share sound, sir.
Just hold 1 minute. I will restart it. Just sorry. The tech. So first I share the screen and at that same time share sound also, right?
Yes, sir. Perfect.
Correct. Now share. And now I go back to this video and restart. Now tell me if it's better.
The other way of accessing sputum or
Perfect.
respiratory
Yes, sir.
secretions
Yes, sir.
in small children who tend to swallow it is to collect it through the stomach. And that can be done if the stomach contents are not mixed with any food articles, which means we need to do this procedure after either an overnight or a few hours of fasting. So often we call these children after an overnight fasting, put in a tube into the stomach and collect all the secretions which the child may have swallowed during the night. We call this procedure as either gastric aspirate, or sometimes, since the aspirate alone will not be enough to get the material from the stomach, we may have to put in some saline to lavage it. So it is also called as gastric lavage. In this clip, we'll learn about gastric aspirate or gastric lavage.
To begin with, explain the procedure and take consent from the parent or guardian. Patient should be fasting for 4 to 6 hours prior to collection procedure. In an admitted child, it may be done early in the morning while the child is still asleep and in bed. Instruments required for the procedure are normal saline, pair of sterile gloves, Ryle's tube or infant feeding tube, adhesive tape, lubricant jelly, 5 ml syringe, sterile specimen container, face mask, sterile gauze, and measuring tape. Place the patient in a supine position and restrain using the long folded sheets. One end of a folded sheet is pulled over the back of the child, looping through both the arms as shown. The other end is then rolled over the arms and wrapped around the child, moving from back to the front and then to the back. The lower end of the sheet should be reaching the wrist of the patient for effective restraint. One could make this measurement directly using the tube or else using a measuring tape. The Ryle's tube needs to be placed in the body of the stomach through the nose. The required length of the tube to be inserted can be ascertained by measuring the distance from tip of the nose to the tragus and then from tragus to the midpoint between xiphisternum and umbilicus. Apply lubricant jelly to the tube. Gently insert the tube through the nose in a direction perpendicular to the face up to the measured length. This can often be assisted by asking the patient to swallow. fix it to the nose with an adhesive tape. It is important to confirm that the tube is correctly positioned in the stomach. This can be ascertained by pushing some air with a syringe into the tube and simultaneously auscultating for gush of air over the epigastrium with a stethoscope. In case the patient starts choking or coughing while inserting the tube, then the tube should be withdrawn and reinserted after the patient has settled. Once the right tube has been inserted into the stomach, its position can be checked by hearing a gush of air over the epigastrium. We can also aspirate the stomach contents to confirm the position. Gently aspirate from the tube, keeping the patient in the supine position. If there is no aspirate or the quantity is inadequate, try re-aspiration after shifting the patient in the left and right lateral positions. If one still does not get adequate specimen in both supine as well as lateral positions, further aspiration can be retried by shifting the tube a little in or out in an effort to hit the stomach contents. The repeat aspiration should be done while rotating the patient through supine and lateral positions. In case direct aspiration fails to provide adequate specimen, one should instill about 10 ml normal saline through the tube slowly. Align it to gravitate on its own. After instilling, re-aspirate, rotating the patient through supine as well as left and right lateral positions. Repeat these steps till gastric aspirate is obtained. Collect the aspirate in a sterile container. A specimen is considered adequate if it contains about 10 to 15 ml of stomach contents. After collection of gastric aspirate, gently remove the tube by closing its cap or pinching the tube. "50 ml conical tube is another type of container which can be used for sample transport instead of the disposable container shown in the video. As conical tube can be put directly into centrifuge machine, it is preferred when the sample is to be subjected to mycobacterial culture and drug sensitivity. This is also the preferred container for samples being sent to National TB Program labs, as it does away the need to transfer the specimen from one container to another.
Well, that was, I think, a wonderful video showing very, very precisely all the steps, and I'm sure most of the people who follow these steps will never fail to get an aspirate. Now, over to you, Dr. Bajania, to start with the treatment therapeutic dilemmas and consensus.
Yes, sir. Now, Dr. Vijay, sir, during our residency days, I vividly remember that whenever patient didn't improve due to any condition, I mean, we used to start as a last resort ATT. So still it is relevant, any role of empirical ATT still?
Well, good evening, everyone. And thank you, Nitin, for showing that video on gastric lung. And I hope, like induced sputum, more and more members would start using this modality to get a sample of sputum for establishing a definitive diagnosis of tuberculosis or ruling out tuberculosis. And before I elaborate, one-line answer to your question is no. There is no role of empirical treatment for tuberculosis. Now, the way we have been managing TB in the past has totally changed. There is a total shift, and what we insist on is complete and confirmed diagnosis. Confirmed diagnosis by a microbiological diagnosis, either by growing the bug or demonstrating the DNA of the bug, that is your gene expert, which is now fortunately available through the program and even otherwise very widely available. And we also try to demonstrate if the isolated DNA or the grown bug is sensitive to first-line agents or no. There is a difficulty, there are challenges in establishing this microbiological diagnosis. However, as shown in the videos and as we saw in the previous session, if one really makes an attempt, it is possible to establish a microbiological diagnosis. If you do not do that and put a child on empirical ATT, you are likely to, you know, uh, you know, include in that umbrella both drug sensitive as well as drug resistant TB, because clinically it is impossible to differentiate a drug sensitive from drug resistant TB. So if you subject a child who has probable drug resistant TB, you would end up, exposing him to ineffective drug. The disease would grow. He would also continue to spread the disease to the close contacts. So it would only propagate resistance, and that is what has happened over the period of time. So there is no role of empirical ATT. However, if your suspicion of TB is very strong, you have a very strong case of presumptive TB, and all your attempts fail to establish a microbiological diagnosis, and if you have ruled out other diagnoses, one may thoughtfully and carefully label such a child as having probable TB and put this child on tuberculosis. But this is an exceptional situation, and what is important is go all out to establish a diagnosis and rule out other conditions which can mimic TB. And then label and put this child under surveillance, even if you start this child on ATT. So this is a probable TB. So there is no role of empirical.
So, Dr. Yevle, we have been really over-treating many patients as TB without actually diagnosing, and we are surprised ourselves as to how many of them actually didn't need it, besides missing an MDR, which can cause a problem. The second question that we probably need to learn or de-learn, Dr. Sushant, is there? I mean, there used to be dots in the past. Now, is it still relevant or is it given up now, at least in children?
So DOTS, as we know, when the program started, we had a directly observed treatment.
Yes.
Right. The patient had to go to the NTEP center. I mean, that time it was a RNTCP, not NTEP.
Correct.
And the treatment was given observed, because the main thing was, one, to improve the compliance, and second, it was initially, especially in adults, in children we never followed, it was an alternate day therapy. They used to do twice a week. Now this has all changed when we turned to NTEP. It has become a daily therapy. Okay, whether it is children or adult, it is a daily therapy. So we can't expect the patients to go to the NTEP center daily, right? So DOTS, they have changed the concept of DOTS. DOTS has taken a backseat. Now there is something known as a treatment supporter concept, which has come up under the practice. So what do they do is they counsel or take into confidence the family member immediate of that patient. First preference is given to a family member or any close associate, even a good neighbor or a close friend who is willing to take care of the patient, and then he is made a treatment supporter, and then the treatment is started to the patient, and the drugs are given, 2 weeks drugs or sometimes a month's drugs are given, and then the what you can say, the checkpoints remain same. That is, we have to, the patient has to show the empty blister packs and all those
pill
things.
counts. Yeah.
Pill counts and everything. Then there are certain modern ways, app-based systems have been developed. There are something known as electronic boxes where the patient, the tablet is opened, there is a number, the patient has to dial a toll-free number. So these are the ways the program is doing. It is advancing technologically also. So DOTS has gone back. The patient does not go to the center, but we have created treatment.
So there is someone observing the treatment from home or nearby who will help improve compliance and motivate the patient, because sometimes these patients are sick of taking medicine every day. I mean, how many of us finished a 7 days of antibiotic course? Someone taking 6 months, and in MDR 12, 18 months, 2 years of treatment is not a joke.
And not only the treatment supporter, but even the treatment supporter is under scrutiny by the program person. So we have, hierarchies of people like an SDPS or a HV or a house visitor. So if a patient skips a visit, or the program people think something is going wrong, initially a phone call is given to the patient or the treatment supporter. If still there is something they feel fishy going on, then the house visitor goes to the house of the patient. So this is how monitoring happens.
Perfect. Ramesh bhai.
Basically,
yes, Dwarinda Singh.
We are shifting from facility-based DOS to a family-based DOS.
Perfect.
Yes. So that is what it is. And Sushant very correctly mentioned the reasons for it, which is that we went to daily therapy. So it was not possible for people to go. And reason for taking daily therapy was that we have found that if you have high INH resistance, then intermittent therapy can possibly be, if there are any missed doses.
Correct.
So there was no margin for error in that.
Correct.
Yeah. Now, Varinder sir, there are so many fixed drug combinations. So it's a really a problem, and how we can make the ionate dose like 10 mg per kg. So please guide.
So there are two varieties of fixed dose combination. One fixed dose combination is all the inaccurate ones which have been there in play for a long time, right? And then there is a new WHO provided combinations like 50-75 and which are made largely globally by two of Indian companies only. Namely, Lupin and MacLeod are the one which are making. Then Schwarzer is also coming up. So there are not many players in the market on this. However, as of now, most of their production goes into the national program.
Correct.
Very little of this reaches the private market. So sometimes some batches do, but not much of this is available. So most of the available FDCs outside of these will not give you all the three drugs in this right combination. There are some local companies which are mimicking the product, but they have not established the bioavailability.
Correct.
So we do know that bioavailability of these drugs is affected if they are put together in combination, particularly of rifampicin when all three or two are combined. So therefore, be very watchful about using FDCs outside of the program because either you will underdose or you will have to titrate and it will increase the pill burden. The advantage of the FDC which is made now is also that it is a dispersible tablet. So even though it is going to a much smaller weight band as a one tablet, and you have three tablets for an older patient, actually it is 5 ml. Whether you dissolve one tablet or you dissolve three tablets, all you need is 5 ml of water.
Correct.
So it actually does not increase the pill burden. The only difficulty is ethambutol, because ethambutol is a hygroscopic drug, and that DT somebody has come up, but so far is not available under the program.
Correct.
So they get added. And when you go to older children, we use a mixture of adult type of FDC and a pediatric type of FDC. So very important thing for us, our friends here to know, because sometimes you may send your patient for drugs to NTP, but the patient may stay with you for rest of the things, which should ideally be the way that it should be this way. So the adult FDC is a 4-drug FDC. So that has R, H, Z, and E. So pyrazinamide, ethambutol, INH, and rifampicin. Whereas pediatric is R, Z, and R, H, and Z. For intensive case,
E is separate.
E is separate for pediatric. So for adults, it's combined because that's not a dispersible term.
Yeah, perfect.
So, Dr. Varinder, I mean, now we say 10 mg of INH, 15 mg of rifampicin, and 35 mg of pyrazinamide, which means the fixed drug combination of pediatric should be 10:15:35, whereas what is existing is 50:100:25. So we are underdosing all the three drugs. You can make up for INH by adding a solo INH tablet, half or one, depending on weight, but you still cannot correct the rifampicin and pyrazinamide. Otherwise, you'll have to keep on adding each one, three of them separately. Then there's no point in having FDR. So why are this type of FDR, which are not into correct ratio 15:10:35 available? I mean, why cannot we write to the government, or why can DCGI not take those same companies? They can add that much and make this trend different. I mean, they don't have to really do something very different.
Correct.
That's a very valid point, and I think that's where the role of IAP comes.
Correct.
We should be writing time and again. Government says, look, we have created a product. We have told you this is the right one. If there's something exists which have been cleared by
Drug
control for any reason, that till we lobby it against it, it will not go.
So I think if one commercial company comes with 15:10:35 and everyone starts writing only that, the others will follow. But till the time first company comes out like that, it's going to be difficult, and that's where we'll have to keep on
The sad
juggling.
part, Nitin bhai, the sad part is that none of the companies is interested in the pediatric TB market, whether it is first line drug or a second line, particularly for second line drugs. They don't do anything. Neither the Indian companies. Bedaquiline has gone off patent. They are willing to make up for adults. Cy TB. Serum Institute bought it for diagnostic purpose they have the global rights. They are still to come to 12 years or below, because nobody wants to spend time, money, and effort for pediatric cases, because they're far too less than the older population, which is a sad story. And that's where I think the advocacy role of IAP has done some tremendous, played an important role in vaccination, in many other things, the ORS. So we must,
Yes, sir. It
we
is very
are,
well
I mean,
noted, and I
doing a lot of
definitely
work even in
represent
the
it.
field of TB, but this is one part of advocacy where we need to really push it.
Noted,
But
sir.
at the
Noted.
same, but at,
Now,
Nitin, at the
Vijay,
same
sir.
time, Varinder Singh, just correct me if I'm wrong.
Yes, sir.
The currently available FDCs, if you look at the dose range of each drug and the weight band, they are more or less, the dose delivered is not suboptimal. If you go to see, it
No,
has
Dr.
tremendous
Yevle, let me ask you one question. Suppose you have a
50,
10
75.
kilo child and I write a fixed drug combination. It will have 100 milligram of INH.
And
I mean,
150
it will
of
have 50
rifampicin.
milligram. No, it will have 50 milligram of INH.
Give two
100,
tablets.
no, 100 milligram of rifampicin. It will become double then. The
No,
ratio is not perfect. What I mean is,
FDC is 50, 75, and 150.
but many are not like that. Many are like
No,
50.
what is available under program as compared to what is
I'm not talking
available
I'm
in
not
mass?
about private practitioners.
Acha,
Our
private.
today's focus
Okay.
is only on private practice, because
Yeah.
people are wanting these answers. Then you have to juggle by adding INH 5 mg per kg extra to make it 10 mg. Then you juggle to make 15 mg
Absolutely.
rifampicin by adding 5 mg more.
Agreed.
I mean, there is
Agreed.
no end to this game.
Agreed.
So that is
Absolutely.
the question.
That
Yeah.
agreed.
So that brings me to you, Dr. Vijay Evle, that we are now using more doses than what we should use before. I remember when I was a resident, we used to give 15 mg per kg of INH and sometime up to 30 in a TVM.
Yes,
I
sir.
don't know. We were really shocked to hear that a lot of people used to get hepatitis, but it used to cure patients sometime that time. Then we came down to 5 mg, now again 10, then rifampicin. So by increasing these doses for pediatric recently, as per the NTP, is it leading to more toxicity actually in patient? Have you seen, or is it okay that tolerable?
Fortunately, children tolerate anti-TB medications much better than adults, I would say. And apart from those routine vomiting, gastritis, intolerance, major side effects like say your hepatotoxicity is not all that common.
Yes.
You do come across hepatotoxicity. Then, since INH dose has been stepped up, one needs to always remember that many of these children are severely malnourished. So one needs to be a little careful about pyridoxine deficiency. And that's
Absolutely.
now we have started the program recommends that we must give 10 mg
Yeah.
per kg in drug sensitivity and
We'll
higher
we'll
dosage.
we'll come to
DRP.
that. We'll come to
So,
that a little later.
so
That we need to give them.
otherwise the drugs are tolerated pretty well. Even the ethambutol, which is continued in the continuation, is reasonably well tolerated, and so-called toxicity, the eye-related toxicity is not all that common.
Correct. I think that brings us to the most important part of today's treatment. Everyone knows drug sensitive TB. To treat reasonably, I think an average pediatrician will be able to treat the drug sensitive TB reasonably. What really is challenging is for them to understand the drug resistant TB. So Sushant, there are so many terms which I use. So we have a mono resistant, we have multi drug resistant, we have poly resistant, we have pre-XDR, we have XDR. There used to be a term coined by one of the pulmonologists in Indonesia as a TDR, totally drug resistant, and so on and so forth. Of course, so can you define quickly what is, let's say, mono resistance? What do you mean by mono resistance?
So mono is, as the word suggests, resistance to any one of the first line drugs.
But not rifampicin.
Yeah, rifampicin is given a special category. Okay, the reason is being, like we said, when we define, so mono resistance is any first line drug. Okay, resistance is there. Poly is any to more than one of the first line drug. However, not rifampicin and INH together.
Correct.
So these are the two definitions what I would like to say of mono and poly.
MDR.
Now coming to the question of R resistance and MDR. Okay. Now R resistance, as we know, CBNAT or whatever we are using, CBNAT or Ultra, it picks up R resistance only. Now why it is being done is because that is the most critical drug when we talk about treatment of tuberculosis, rifampicin. Okay. And if we see when the CBNAT picks up R resistance, it is the patient is also considered as an MDR, multi-drug resistant TB, and started on MDR treatment. However, technically, if we see the definition of MDR is resistance to both INH and rifampicin.
Correct.
Why this is being treated is because most of the patients who are R resistance, more than 80%, 85% would be concomitantly resistant to INH.
Correct. So it's a surrogate of two drug resistance.
Yeah.
Yes.
So very few number of people or patients would be there who will have a mono R resistance without a H resistance, and that
Correct.
is why R is considered for treatment purpose to be an MDR TB.
Correct.
Now going one step further, we have a pre-XDR and we have an XDR.
Correct.
Okay, so pre-XDR is a relatively new entrant in the definition. Initially, we didn't have pre-XDR.
Correct.
Now, for understanding that, we must understand the basic grouping of the second line drugs. Because WHO has given, or even the Indian guidelines have adopted, we have three groups of drugs: Group A, Group B, and Group C.
Correct.
A being the drugs which are most effective, efficacious against the disease, and then we go down in the efficacy. So in the group A, we have drugs like we have bedaquiline, we have quinolones, levoflox, moxiflox, and we have linezolid. Then group B, we have two drugs, clofazimine and cycloserine. And then rest of the anti-TB drugs come in group C. So we have our aminoglycosides, we have delamanid, pyrazinamide, ethionamide, everybody would be clubbed in group C.
Correct.
Now coming to the definition of pre-XDR on this background, if we have a MDR with additional resistance to any of the group A drugs, okay, any one or both of the group A drugs, that is either what you can say, sorry, pre-XDR is I'm sorry, pre-XDR is MDR with resistance to your quinolones.
Quinolones, fluoroquinolones.
Any of the quinolones, that is levoflox or moxiflox, it is labeled as pre-XDR.
Correct.
Again, so we have, if we, I mean, when we, if you go back to last time's discussion of our LPA, we have a low dose and a high dose moxi resistance. So that should differentiate any type of resistance to a quinolone which is picked up. The patient is classified as a pre-XDR TB.
Correct.
So this is the definition of pre-XDR. Now coming
and that
to
will be evident on the second line LPA if you have a culture positive or a very strong sputum positive. Correct.
Yes.
Now go ahead to XDR.
Last is the XDR. So we have the criteria of a pre-XDR, that is it is MDR plus a quinolone resistance plus resistance to either any one or both of the group A drugs. So like we said, group A had bedaquiline, quinolones and linezolid. With quinolone, it was a pre-XDR. Along with, if it is resistance either to linezolid or to bedaquiline or both, it becomes an XDR. This was a change because the older definition had an injectable resistance. So that change now to these bedaquiline and linezolid. The whole reason being now we are all moving towards injectable free regimens for TB.
Okay. So I have a subsidiary question that the MDR TB that we see in children, is it because of inadequate or haphazard treatment in children themselves, or they are the innocent bystanders of adults having not been treated well in the community, or both?
So that is the concept of a primary and a secondary MDR.
Correct.
Primary is when the patient inherits a resistant bug from the index case, and secondary is what we just discussed, that the patient either has taken the treatment inadequately, incompletely, or poor doses and the bug has mutated. So in pediatrics, what we see most commonly is a primary MDR, that is they are inheriting the drug-resistant drug from a close contact in the house. That is the most common variety what we see, and that is why we know sometimes what happens is when we are treating, we will see that in the treatment part, we do all the attempts, we do microbiological attempts, even with a BAL and invasive, everything comes negative. Okay, but if there is a history of there is a patient in the house who is on MDR treatment, we are starting the child on MDR treatment from where it has achieved. So children are mostly primary.
Perfect. So, Dr. Varinder, when we are treating MDR TB and then we are having these new drugs, the delamanid and the bedaquiline, and there are lots of talks about can you reduce the duration of MDR treatment, because 18 months, 24 months is what we should talk in past with the new drugs. So there where the question comes, what is an extensive TB, what is a severe TB, what's a mild TB when it comes to MDR? Can you define that little so that people understand what are we talking about?
Right. So one of the concept earlier was the XDRs and other drug resistance. Now the most of what we are talking of is MDR, which is rifampicin resistance, right? So when we say rifampicin resistant with or without fluoroquinolone, which could even be pre-XDR, what you get in those situations is you look at whether you have a pulmonary case which is non-severe. What is a non-severe pulmonary case? Which is a unilateral localized disease, or you have a unilateral pleural effusion. or you have a lymphatic disease like a localized lymph node. So a relatively possibacillary situation, as one would like to say, though they're not truly possibacillary, because once you have a parenchymal involvement, some of these may even be smear positive. So these are the patients which are called to have non-severe EPTB or mild pulmonary disease, and they are the one who can be treated by a shorter drug regimen, which earlier was also called Dhaka regimen, but that Dhaka regimen has actually evolved and changed a lot. So it is just now today called a shorter regimen, and which contains bedaquiline, which contains which is given. Bedaquiline is in our country allowed above 5 years of age.
Correct.
So therefore, below 5 years, we cannot use this, and bedaquiline is used for 6 months.
Correct.
It is followed by levofloxacin, linezolid, clofazimine, and cycloserine. That's the combination we have for under 6 years. But
Correct.
in the under 6 years, basically, sorry, I somewhere mixed up the drugs. Let me repeat it again. You have high dose moxiflox with bedaquiline, with ethinomide, clofazimine, and you have 3 of the first line drugs, which is pyrazinamide and high dose INH and ethambutol. So then concerns also came that because of QTC prolongation, which is one of the difficulties with bedaquiline, now we often, when you're using bedaquiline, you prefer to use levoflox rather than high dose moxifloxacin. So that's what the intensive phase is for 6 months. 4 to 6 months. You can, after this, what you stop is the high dose INH, and what goes down is also the bedaquiline. In a child who is younger than that, 5 years of age, where you can't use bedaquiline, now the replacement drug is delaminate, because delaminate is very recently allowed in India till the weight band of 10 kg.
Correct.
Right. So if you're 10 kg and above, you can use delaminate. Otherwise, you will be forced to use an injectable, which is rather unfortunate, because it's hardest to give an injectable to a small child, and also hardest to monitor the ocular toxicity of injectable in a small child. But for regulatory reasons, we are not able to use.
Correct.
So this is the non-severe extrapulmonary or mild pulmonary disease where you use the shorter drug resistance.
Correct. But you can't use that in neuro TB, or you can't use it in extensive fibrocaseous. You can't use it in cavitary or any other severe forms, including skeletal tuberculosis. Am I correct?
And you cannot even use it in a pre-XDR TB. The moment you have a resistance to any of the drugs which are used in shorter regimen, other than the INH or ethinomide, you cannot. If you have resistance, that is where the business of first-line LPA, which Sushant was alluding to, CAT-G and INHA. If you are resistant to both, which means then both ethinomide and high-dose INH would go out of the regimen, then you can't use shorter regimen.
Yeah, but Dr.
XDR, XDR, you cannot use shorter regimen. You have to go on a longer regimen. Available regimen, which is routinely recommended for long term, is for a pre-XDR. For XDR, it is actually an individualized therapy, which you have to create out of the A, B, and C.
And for that, you will need all the 13 drug phenotypic DST as fast as possible, probably, because beyond the second line LPA, you have no way to know which are the other drugs which are going to be really useful.
Absolutely.
So that brings me to me.
That's where you get hold of Sushant.
Yeah. So what
Nitin and Varinder, I have, while non-severe TB is defined as mediastinal node,
or lymph node,
I believe that node with airway compression is not included in non-severe TB.
It becomes severe.
It becomes severe.
Essentially, peripheral lymph node, or maybe a pleural effusion type, or those types.
Even mediastinal without compression is taken as non-severe.
Yes, correct.
But
actually, there is a little bit of a confusion there. I didn't want to go there, but since you raised Vijay, so there are two different types of definition of non-severe in circulation. The definition which you are talking of non-severe came in the context of the SHINE trial, which talked of 4-month regimen for drug sensitivity. That is where the talk was about compression or non-compression.
Correct.
If you look at the WHO guidelines or Indian national guidelines on drug resistance TB, it just says localized disease in one lung. It does not say go beyond into classifying, because when these are gradually the same the guidelines which came for adult, then we fine tune them to bring it to pediatrics. So one of the difficulties, you see, earlier when we started trying to introduce pediatric inside the program, we suffered a lot because we were holding on to our fort. हम ये कह रहे हैं pediatricians को ये चाहिए आप ये दो. Program would not listen to us because you realize their difficulty was that one change and the training across the country for that change was so difficult and so much confusion between pediatric and non-pediatric at the periphery that they found it very difficult to handle. So then we found that if you have to enter this camp, then you have to make a compromise to the extent that the child is not hurt. Do not create, because then we also realize that while you see, the best cannot be enemy of the good. If good can be done to most patients, then accept it. It doesn't matter.
Perfect.
Fine tuning can be left out.
Exactly. So last question before I hand over to Dr. Ramesh Bhajan and Dr. Varinder Singh is that we all talked about this choice of drugs, MDR, first line LPA, second line LPA is when you have a gene expert showing R resistant or a rapid culture which is positive, which is where you can do an LPA or a DST. You have neither gene expert positive nor you have an LPA available. In such case, where would you think of starting only first line, or where would you think of starting directly an MDR type of treatment?
So that
because this is a dilemma in pediatric practice in many centers, especially because in big cities it's very easy to get all these cultures and so many fancy things done. At the periphery, I'm sure it's not as easy, though we may say that every district has a gene expert machine, etc. But I have seen even in best of the best cities, cartridge is not available for few weeks, etc. And then the pediatrician is pushed to the wall.
So if you have anything to suggest drug resistance, then you should not take a short route. If you are in the village and you need a LED TV, you go to our nearest town and buy it. People go
Correct.
even to fetch a pizza to a nearby town.
Correct.
People from Delhi go 100 kilometers to a highway dhaba to have a delicacy.
Correct.
And I'm not talking about it's just a middle class fad. It's just a fad. So where it is required, we have to make an effort. So where it is required, I'll define that for you. If you have a patient who has been treated in the past and has failed on drug or relapsed.
Correct.
If you have a patient who is not improving on the first line.
Perfect.
If a patient has come from a background where there is an exposure to MDR TB.
Correct.
So either a known case or the source case has died. Because
Correct.
death due to drug sensitive TB is less common. So you
Correct.
assume. And
Correct.
these are the patients where you would make all efforts. But if your efforts fail because the sample is not there or sample is there but test comes negative, MTB not detected, it's possibacillary, then we label them as probable TB and go on to giving an empirical basis a drug resistance. But mind you, drug resistance TB is not that simple a game as drug sensitive. Much longer, much more complications.
Correct.
So your cost to benefit ratio, cost in terms of they're expensive also, but cost in terms of the side effects, much higher. So one cannot take it lightly. It has to be really that you can't get a specimen.
And if you have a drug sensitive TB, then the best drugs are the first line because they are the most potent drugs. If you treat them with MDR, even 6 drugs, there's not going to be substitute. So MDR is for drug resistant, not because they are better. So they are second and third line, not because they are better, because they are the only ones which will work in such a patient. Right. Ramesh Bhai.
You couldn't have said that better, Dr. Nitin.
Yes.
And what is important here is to underline one fact. We often carry with us this, legacy or hangover of antimicrobial and antibacterial being mixed up. So when we think of antibiotic, we think of higher generation antibiotic being more potent and more better.
Correct.
Even though that is also debatable. I'm not going there in that area. In the context of TB, it is absolutely not true.
It's the reverse.
It could be reversed. So one has to be very cautious.
Right. Ramesh Bhai.
Yes. Vijay sir,
Yeah.
does it mean that R resistant means always MDR?
Yeah, as Sushant alluded to it, R resistance is always treated as multi-drug resistance. It is never rifampicin resistance alone, unlike your H resistance, which there can be a mono resistance to isoniazid.
So what is the percentage of monoresistance INH, Sushant, you had mentioned?
Around 15 to 20%.
That's quite high, yeah. But you can overcome that by giving 15 mg per
This is
kg or
the
not
country
in.
data. We don't have pediatric specific data. Overall in India, it is reported as around 20% of INH mono. We do see, we are seeing in pediatrics also nowadays. So I don't have a proper figure to give which is quoted in the program. But for at our center, I can say in a year we are seeing 4 to 5 patients.
But can you overcome it by giving high dose INH, or you just cannot use INH?
No.
No. Okay, Ramesh bhai.
So that is the
Yes.
third kind of regimen which we have for a DRTB. So we had
Right.
spoke about a longer regimen, we spoke about a shorter regimen. If we happen to diagnose a H mono, then we have a uniphasic regimen of 6 months where so we had a traditional regimen of HRZE. Because H is resistant, we remove the H and we replace it with levofloxacin.
Levoflox, perfect.
Remain and it goes on for 6 months.
Perfect. Ramesh bhai.
Yeah. So now, Vijay sir, what regimen for first line, how long, what monitoring and toxicity? Please guide.
Yeah, for most of the viewers who are watching us today, this is extremely important. Yeah. So while we discuss
I would
MDI,
say the other way, they should only
yeah.
venture into this and the rest all leave it to Dr. Sushant, Dr. Varinder, and Dr.
Absolutely,
Yogi.
absolutely. I mean, treating drug-resistant TB is not all that easy.
Correct.
It should be left to the pediatricians or experts who are used to treating drug-resistant TB.
Correct.
Having said that, unlike your resistant TB, the therapy of drug sensitivity is biphasic, and Nitin put it very correctly. These are the medicines which are the most effective medicine in drug sensitivity. So it consists of an intensive phase of 2 months wherein you use HRZE.
Can you elaborate the dose also so that we are again reiterating the correct doses?
The dose of rifampicin is 10 to 20 milligram per kg. That's the range, and you end up giving about 15 milligram.
Correct.
Then for isoniazid, it is about 7 to 15. You give about 10 milligram per kg. That's the range given. Then for pyrazinamide, it is 30 to 40 milligram per kg. Ethambutol is again 15 to 25. And that is how you give.
So reasonable to say 10 mg per kg of INH, 15
10,
mg per
10,
kg of
15, 20, and
rifampicin,
30.
35 and 20. Yeah, right. Now, how long, how to monitor response
So
and
2 months is
toxicity?
your intensive phase, and the 4 months is continuation phase where you take away the pyrazinamide. It is the pyrazinamide which has helped us shorten the duration. If you remember, in the past, we used to treat TB for 9 months and year at one and so forth. But thanks to pyrazinamide, that the duration has been shortened to 6 months. Now, having put a check, again, at least wherever it is feasible and possible, we could refer these patients to the program. They can, private pediatricians can, get the drug from the program, and the patient can take it, and the private pediatrician can deliver the drugs to the patient. The availability of drugs was an issue in the past, but at least in November area, we are reasonably comfortable, and the medicines are very readily available, and we do send our patients to the program. And sometimes
let's finish the course. Then what happens after 2 months?
After 2 months, you continue HRE, isoniazid,
same dose.
and along with this, you also give pyridoxine. 10 milligram is the dose that is given, and then you monitor.
So older child will be even 20 or 40.
No, in drugs, and most of them get 10 mg per 10 mg of dose. It is in drug resistant TB where the dose is higher.
Correct.
And then monitoring, you call them at the end of a week or two, and just to ensure that they have understood the regime correctly, they are adhering to it. If possible, ask them to get the empty strip and have a pill count. I usually ask them the color of urine. That tells you that the child is not throwing it in the wash basin and actually consuming it. And then you monitor
toxicity monitoring. Do you routinely do their blood tests?
Routinely before starting, liver enzymes are not recommended. However, if a child on follow-up or while monitoring, if you come across something indicative of a problem,
or icteric,
you would certainly do it.
Correct.
And then you call them every month for 6 months. Even after completion of therapy, you should ideally monitor them for next 2 years, every 6 months. And when you call them for follow-up, you do clinical monitoring. First of all, assess the symptoms for which you have put the child on ETT, those cardinal symptoms, how well they have fared on that front. Then you also keep a good weight record. The child is because ultimately one needs to in this era of drug-resistant TB, which is increasing, one needs to monitor and pick them up early if your child is failing, if the first line agent drugs are failing.
Perfect.
Then you
do you repeat an X-ray or you don't repeat an X-ray at the end of the
you
therapy?
repeat at the end of therapy.
Therapy. You do repeat at the end of therapy. And
And
suppose you see some
you know,
persistent shadows, but the patient has improved. You continue the drugs for another 2-3 months, or you just stop it and observe.
so there is no if the patient has otherwise improved, by and large it is not continued, because one has to keep in mind a possibility of paradoxical upgrading response. That is one.
But
And
that patient would be symptomatic with high fever and lymph node appearing or something. But is an asymptomatic patient, only the shadows are persisting.
If the shadows persist, there is no a fixed answer. It will have to be immobilized. It will have to be.
Sushant, what do you do in JJ? Suppose the shadows persist, you just leave them
So,
alone?
Yeah. So, like we said, we see three important things: whether the symptoms have gone, whether the child has gained weight, okay, and whatever he had started with, it is all gone. Again, gain weight is a subjective thing. Some patients would get, we have seen, would gain 8 to 10 kgs of weight. Some patients would also gain 3 kgs of weight.
Correct.
So it all depends upon not only the anti-TB, but what nutrition the child is getting.
Correct.
All has to be taken into account. And if only the shadow is persisting, we don't do anything, just keep the child under follow-up. One
Perfect.
message I want to give here is, we don't do it in JJ, but we have seen at other places, where funny shadow is seen and the people get a
CT scan.
You should not do all these things.
Correct. One CT scan is 150 X-rays radiation, and more than 2 CT scan in your lifetime, and your cancer chances go up.
That is one thing, and second thing is CT scan is such a high sensitive this thing.
Correct.
It will pick up some nodes,
something absolutely,
showing some funny things, and then the AKT is 9 months and 1 year, and all those funny business goes on.
It's like ultrasound showing some 20 ml of pleural fluid, which is normally seen also in the patients. Absolutely.
So like this X-ray, once the patient has completed the treatment, right?
Yeah.
So when does the need arise to repeat a gene expert or AFB or culture?
Yeah. So when we talk about pulmonary TB first, okay, we have done it at the diagnosis at the beginning. We have done a gene expert and a culture. Now, as we have discussed in the diagnostic part, gene expert is a molecular test, so it picks up DNA. Okay, so it is not a recommended test to be done for follow-up. Okay, because in follow-up, even if a small portion of DNA is remaining, it can flag positive, and we don't know whether it is a live bacillus or a dead bacillus. So for follow-up, the two tests which are recommended is a smear and a culture. So when we say, suppose the child was microbiologically positive at the beginning of treatment, to demonstrate microbiological conversion, okay, we do a smear and we do a culture. We don't do a gene expert.
Correct.
Whether it is MDR or whether it is drug sensitive, the protocol is same. Just in MDR, we do it more frequently. The guidelines are different. In drug sensitive, we will be doing at the completion of intensive phase and at the completion of continuation phase.
Correct. Dr. Varinder.
Yeah.
We can't see you.
Varinder, sir, now you have started treatment.
Dr. Varinder, you had raised your hand. You want to say something?
Just wanted to add a couple of things to the previous one. So one is that radiology always takes longer than the symptomatology.
Correct.
So there is no advantage of doing a end of IP or 1 month or 2 months an X-ray, and sometimes you may see more shadows than you saw earlier, because actually those shadow increase within the first week when you had the first X-ray and you started treatment. But you are seeing at the end of 2 months, you infer that they have happened now. They could have happened at any point of time. There is no way for anyone to know when they happen.
Correct.
So we think there is a deterioration and we go after it, or sometimes we see no resolution. So there is no advantage unless until the patient is symptomatic, you are doubting the diagnosis, or you're thinking of complications. Or if you're thinking of failure, then you have to go to the diagnostic way of a microbiology.
So that brings... Yeah, go ahead.
End of therapy X-ray is very important.
Correct.
Why is it important? It is not to show a complete clearance. It is important that kind of becomes a baseline for future. Should this child have say
Recurrence.
repeated cough or recurrence or just the symptoms which may or may not be because of TB, then you would not know. You would have only the first X-ray to compare, and then you would be at a complete loss. So the role of radiology is less, but it cannot be underplayed in pediatrics, because in pediatrics we do not have as yet even the best of the hands and best gene expert. Sometimes is not positive in about 30-40% of patients. So you still have to resort to a clinical radiological diagnosis, and therefore these tools are to be used very judicious.
Correct. So, Dr.
The other point is about weight. Strand very rightly mentioned that not everyone gains weight or is not proportionate. Remember one thing: if a child has not lost weight because of TB, he will not have any regain. What you are seeing is a regain. So he will only gain as much as you expect a 10-year-old to gain in 6 months, which is not a huge amount.
Correct.
So we are somewhere also sometimes stuck with the gaining, which we so often see in infants or younger children, that we expect the same thing to happen in an older child, which is not true, and they have sporadic growth. So I'm not getting into territory of the growth of older child, but I hope I made my point here.
So, as I understand, Dr. Varinder, you're trying to say that if a child has lost significant weight, you expect him to regain that much and maybe a little more over the time. A child who didn't lose much weight should either gain some weight which is appropriate for his age growth pattern. Is that correct? Or at least should not lose weight?
Oh, absolutely not.
Correct.
Oh, absolutely.
So that brings me to the question.
Nitin, I wanted to make a point. Though there is a recommendation to repeat and demonstrate negativity at the end of therapy. To begin with, in pediatric TB, getting a sample is an uphill task.
Correct.
So it is qualified for that. If a specimen is easily available, then you demonstrate, negativity. Otherwise, very often pediatricians do ask this question. So, पहले time GL नहीं होता है, आहिस्ते होता है. I mean, do you expect us to repeat it and document, cure?
Correct. So that brings me to the question, Dr. Varinder. We said all this in a patient who is responding, and you say weight gain or no weight loss, etc. But suppose the patient is not responding as you expect on a first line, and your gene expert had shown no resistance. Now, how do you go about it? This time, at least you repeat the test, you do again gene expert, a repeat X-ray that time. I mean, how do you go about it?
So, if your patient is not responding, what can be the possible causes? So, I'll divide into couple of a few categories. One could be that your diagnosis is incorrect. And that would be more often when you do not have a molecular diagnosis or a microbiological diagnosis. Then question your diagnosis, whether your diagnosis itself is correct or not. Because a non-TB will never respond to TB drug. Okay? You are certain it is TB. Then the second part comes, okay, did we use the right drugs? If we treated the drugs in the right combination, right dose, okay, even that is right.
So compliance.
Then comes third thing, which is the adherence, that child took those, vomited or not vomited, missed or not missed, is the third. All this is fine. Are these symptoms explicable by have record and not a persistent, are explicable by a comorbidity? Somebody getting a secondary bacterial infection or something else, treat that. Because God doesn't give you an insurance that you had TB, so therefore you will not have your quota of typhoid.
Correct.
Or pneumonia. So you look for that. You have ruled all this out. You will strongly keep a possibility of drug resistance, and that possibility will be much higher if this child has any of the risk factors which we talked of a little while ago.
Right.
There you will not waste time looking for typhoid or other reasons. There you will straight away, because why we take time, go stepwise, is because a pediatric specimen is different to access. If it was not difficult to access, then that should be your first thing. In addition, now which test to do is the second question. We still would do a gene expert or a TrueNAT simply because if there is a acquisition of drug resistance now, that's the most rapid way available to you to know child has now RIF resistance. The earlier was RIF sensitive. It could be the standard hetero resistance, and now the predominant drug resistance bacilli are showing up, or it could be an acquired resistant. That's a theoretical discussion, and there is no need for a clinician to bother about that because it doesn't impact your decision on treatment, right? So, therefore, repeating a CBNAT in this situation is useful only for the purpose of knowing RIF resistance. It is not useful for the purpose of saying you do not interpret this repeat test as same as smear positive. The answer to that, whether there is a continued activity, will come from culture. So you have to send a culture. If culture comes positive, then you know this is a child who has not responded. But your decision making will start early. The advantage also of sending a culture is, suppose your repeat test still shows MTB is RIF sensitive, then your possibilities are this is a child, either a child who will take little longer than 4 weeks to respond, so you wait. But that's your last thing. Your first is that are you missing something? You don't want this child to get into trouble. So the other possibility is the resistance other than rifampicin, like an INH monopoly resistance. And if you have a culture positive, then using a LP on that culture, you can get within 6 weeks' time a fairly good idea about what is happening to INH, and that will help you decide your next steps.
Correct. Which case you would remove INH and add levoflox.
Yes.
Correct.
But one of the important things particularly in Maharashtra or area like Delhi where fluoroquinolone resistance is very high, is in this situation we must also do a second line LPA to ensure that they are fluoroquinolone sensitive. We cannot just replace it, blindly in pockets of the country where fluoroquinone resistance in the background is very high.
Correct. So I just want to add two more things. That number one, in such cases, maybe a little more aggressive by doing a mini ball or an actual ball to get the sample, because you are going to decide now a very long treatment with toxic drugs. So I think just cannot rely on gastric lavage. If it's negative, you leave it alone. So that's one. Second thing is that every pediatrician who reports a patient of TB through NICSI, he actually gets an incentive at the time of reporting and at the time of closure of treatment in form of some money. Of course, that may not be important from that pediatrician, but there is a provision. And for the patient, he gets every month some money, I think 500 rupees or 1,000 rupees for the protein supplement and nutrition supplement. So please do report all your patient to NICSI, because it not only helps you, it also helps the patient to get money. Many of these patients are actually poor, and it really helps them to get that type of nutrition and other medicines which they may need.
Nitin bhai, let me share with you some of the experiences when we do these training programs. From smaller towns, some of our very busy friends in IAP have told me, we used to think this is just 250 rupees, 500, why bother? But then notification was required, so we continued to notify. So at the end of the day, I realized that I got enough money from my patients that it would take care of my receptionist or a treatment supervisor's salary. So
I mean, I agree, but I think by reporting, the benefit is more to the patient, because the patient is under NICSI.
No doubt about that. But then it's also your obligation.
Yes. In fact, I would pass my share of money also to the patient if he's poor to get something.
You can do anything you wish to. But what I'm trying to say is that people have created treatment supervisor within their own clinics for TB purpose only. Just as you send, reminders for vaccine, they send for TB.
One thing that came out, Dr. Vijay, out of this discussion in a patient not responding to first line, mean the drug sensitive TB, so on, is that there could be a reciprocal or an iris like phenomenon where there is actually not drug resistant, but a massive inflammatory response which would probably die off. So what is this iris? We had heard of iris when I used to treat HIV patients. Then you put them on antiretroviral and they have inflammation which is showing more symptoms. So what is this iris in TB?
So something like what happens in HIV can happen in TB as well, with or without the patient of TB with or without HIV. As the immunity is depressed, as the patient is put on treatment, the immunity recovers, and you could have paradoxical upgrading reactions, which can come at any point in time during treatment, usually about 3 to 4 weeks down the treatment, and can come as late as 2 years also. But as Dr. Varinder Singh said, that you need to rule out other things, and iris or pure is a diagnosis of exclusion.
Correct.
And usually these children have.
So usually they come with what? Fever, increased
would
lymph
come
node
with
size,
fever, but they
new
have
shadows.
either new shadows appear, new lesions appear, or there is increase in the lesion. There could be, say, pulmonary infiltrates which were not present on one side can appear on the other side. There could be increase in the size. There could be pleural effusion, increase in the size of effusion, a new effusion, effusion
And do
appear
they
on
need
the other
steroids or
side.
something, or just continue the same treatment, let
Not
it die
always.
off?
You need not all patients require steroid.
Mm.
Most of them are self-limiting, but yes,
Mhm.
the patient after having ruled out the other conditions, other reasons for this thing, one may resort to using a short course of steroid. But
Some
many
important
of them are self-limiting.
some practical question, Dr. Ramesh. Next question.
Now, Sushant sir, you are dealing with so many patients of tuberculosis, as Nitin sir said in last episode, that any patient and you are there to handle them. So this is a very common situation that a child is vomiting or has abnormal LFT. Now, which drugs can be used in such situation, and what happens to the total duration of therapy? And when we restart the entire course, please throw lights.
Yeah, so this is known as, the terminology used for this kind of a situation is a DILI, which is known as drug-induced liver injury. And when we talk about the first-line drugs, the most notorious two drugs are pyrazinamide, rifampicin, and isoniazid. Okay, so how do we suspect? So first is symptomatology. Like we said, there is no guidelines which say that we do routine monitoring of LFTs, but if the child starts having repeated episodes of vomiting while on anti-TB treatment, or nausea, aversion to food, first do is an, or obvious icterus. If we see, the first
Correct.
to do an LFT, the LFT, if the liver enzymes are raised more than 3 times the upper limit of normal, we would be labeling it as a drug-induced liver injury, or if the bilirubin is gone up more than 2 times the baseline.
Correct.
Okay. Now, once we have such a kind of situation, we would stop the 3 hepatotoxic drugs, that is INH, rifampicin, and pyrazinamide, for at least a period of 1 week or 7 days.
So what do you continue that time? Can you add a injectable and continue ethambutol?
Yeah. So ethambutol. So if the patient is a kind of a serious
Sushant, we have,
yeah.
Sushant,
So
we
if it
have
is,
lost your voice. Yeah, you can repeat
yeah,
again.
can you hear me now?
Yeah, better.
So if the patient is a seriously ill patient, or if the severe extrapulmonary, severe pulmonary, then during that period of 7 days, we would be replacing, in addition to ethambutol, we would be adding injectable drug like streptomycin, and we would be adding levofloxacin for that period, till the
Correct.
time the full complement of AKT is reintroduced.
Correct.
At
And how
the
do you
end
do
of
that?
at the end of 7 days or 1 week, we repeat the liver functions. Now, if the liver functions have come down within the normal range, what we do is one by one introduction of the drug. The
Right.
first drug what we introduce is rifampicin. After introducing, we repeat after 3 days, 3 to 5 days. If it is still normal, then the second drug which we introduce is INH. Again,
Correct.
repeat after 3 to 5 days, and the last drug which we introduce is pyrazinamide.
Correct.
At any point of time, if the LFT should back to normal, we know that is the culprit. Then we need to replace that particular drug. Out of
Perfect.
the pyrazinamide is the most notorious to cause kind of hepatitis.
And what
Another
happens
thing,
to total duration?
yeah. So another, before duration, what I want to highlight here is, when we introduce the drugs, it has to be in the normal full dose.
Correct.
So there is no concept of giving half the dose then increasing the dose. So whatever we have started 15-10, we introduce with the dose. For whatever duration of time the full complement of anti-TB treatment was not given, the regimen gets extended for that duration. So,
So suppose it took 3 weeks for you to do all this jugulary and back to normal, you will add 6 months
3
plus
weeks.
3 weeks.
Yes.
yeah, it depends upon whether
Yeah,
it is
when it
happening in the
correct.
intensive phase or the continuation phase.
Correct. And when do you restart everything? Like suppose this happens in the first 15 days, then
So that is, even if it happens in the first 15 days, the same protocol is followed.
no, then you repeat the intense course, or you just
Yes, we would consider it from day one.
correct. So day one. So if it
Yes,
happens in the first 1 month, you
yes,
restart and six
yes,
more months. If
yes,
it
yes.
during this second phase, then probably just add those
Just
many days
extend
which
that.
are
Yes,
left.
yes,
Okay,
yes,
I think
absolutely.
that sounds very good. All right, Dr. Varinder, I think now in brief, because we don't want anyone to treat MDR TB on their own based on today's diagnosis. The patient, the pediatrician still need to know what drugs are being used.
Absolutely.
So very quickly, extrapulmonary TB first line. I will first take the neuro, like TBM first line, sensitive. How long to give? You said pulmonary 6 months. For neurotuberculosis?
No, 6 months. We are talking of drug sensitive first.
No, first drug sensitive. Pulmonary, we said 6 months. So CNS tuberculosis?
See, 12 months.
12 months. And skeletal tuberculosis like spot spine?
Also 12 months.
12 months. So maximum is 12 months. All right. Now coming to MDR TB, what are the best drug that you use? How long the therapy? We did discuss short course in the lesser severe variety, but general varieties are like where you give long term. So now it is 12 months, 18 months. You use bedaquiline, delanamide upfront, or you add them as a third line. What is the concept today of treatment of MDR TB? In nutshell, I mean, don't discuss too much because people will start treating on their own otherwise.
Absolutely. No, it is important for them to know, because many times when people like me will start, they will still go back to their referring pediatrician to know ये ठीक है या नहीं है. Then if they do not know, they'll say इसमें से ये छोड़ दो या ले लो. That should not be. So the drugs which are there, we use bedaquiline with a moxifloxacin or levofloxacin. Currently, program is predominantly using levofloxacin. So you use that along with linezolid. Okay, so these are our group A drug. So I often remember them as LLB. Okay.
So what is the full form of LLB? Levoflox?
Levoflox, linezolid, and bedaquiline.
And bedaquiline. Okay, perfect.
Right. And then you have two C's as group B, which are clofazimine and cycloserine.
Correct.
So if you have these drugs, then you don't need a sixth drug. These five are good enough.
But if the child is below 5 years, you said you can't use bedaquiline. Then you use
Then if it is below 5 years, then you will have to replace this bedaquiline with a delamanid. If it is less than 10 kg, then an injectable.
Correct. Perfect.
Right. Or an ethionamide is another option you have.
Correct.
Because it's a group C drug.
Correct.
Now the trouble comes when you also have fluoroquinolone resistance, which is quite often the case when you have, MDR and it is extended. You have a significant proportion who also have fluoroquinolone.
Correct.
Then you may have to sometimes use both delamanid and bedaquiline, though usually they are not used together. But you may have. So then a more individualized therapy is required, and there is a replacement sequence which is there part of the guideline. And I would urge each of the pediatricians not to try to remember it, but to know where it is.
Correct.
So when you need it, refer to it rather than trying to remember, because we do not see these cases every other day, like Sushant Mane, that we will remember what's happening. I'm telling you the truth, it is not possible. But you do so many things, including TB, and then within TB, a small proportion of DRT.
Correct.
So it's not essential for everyone to remember it, but if I know where to find the answer, it is as good.
So in past, we used to use moxifloxacin instead of levoflox, and there used to be high dose, low dose based on the resistance. What is the concept of that high dose, low dose?
You see, there are three types of mutations: mute1, mute2, mute3 for fluoroquinolones. If you have mute3, then it is said that high dose moxiflox would work better. Now there are concerns about that statement also, because phenotypically the concurrence to this genotypic interpretation is not always established.
Correct.
So with the routine use of bedaquiline, high dose moxiflox is not preferred.
Correct.
Simply because, one, that this mute3, it may not necessarily still be sensitive to fluoroquinolone, and the second is the bigger trouble of a QTC prolongation.
Correct.
It can affect the use of bedaquiline, which is an important drug for XDR or pre-XDR.
Correct. So the question is, if there is moxifloxacin resistance, is it always mean there is also levoflox resistance and vice versa? Because on your second line LPA, you do levoflox. So you can't really substitute one for other, right?
So, no, it will tell you mute 1, 2, 3 on a second line LPA. But current consensus is that you consider them cross resistance. Though there is a small proportion with mute 3 where moxiflox high dose may work up, may be useful. But because of bedaquiline, anyway, people do not prefer to use a lot of high dose. That's something where it all depends on the availability of tests, how early they come, what other drugs are available. I would not say we don't use it, but it's not a preferred way.
Correct. So first 6 months bedaquiline and 4 more best drugs. After 6 months, bedaquiline goes, and the remaining 4 drugs continued for how long?
18 to 24 months.
So does it depend on pulmonary versus neurotuberculosis? Is there a difference or all are the same?
Yeah. So if you are neuro or disseminated, then you go 24 months. If routine is 18 months.
Correct.
If your IP was prolonged from 6 to 8 months, then your total duration will go up as much.
Correct. So Vijay, from this, it looks that the injectables are out. Unless
Yes.
someone is below 10 kilo. But my question is that bedaquiline, delamanid are not easily available unless it's at one of the tertiary care center which is approved by government, like either JJ Hospital or Hinduja is one of them. I have at least the privilege that I can write that. So what happens to a common pediatrician? Where does he find these drugs? He has to necessarily refer them to higher
Common
centers. That
pediatrician
means.
refers this patient to DRTB centers.
Correct.
For
So
instance, पिज्जा खाने के लिए बाहर जाते हो तो if it is not
correct. So,
there,
so, so
you go.
Sushant, if suppose, I mean, you are in Mumbai, so let me say I refer a patient of MDR TB to you, you evaluate him, you do all the toxicity before, after, and you send back, and then the patient comes and follows me up for a few months and then comes back once in a while to you. Is there like a public-private partnership also in this
Yes.
MDR TB management?
That is what the program is looking towards, a PP, public-private partnership, so that more of the pediatricians in the private circuit get involved. They also learn, and the
Mhm.
patient benefits. Like how, a few moments back, Varinder sir said that
Mhm.
even though we start, the patient basically is comfortable with his or her own pediatrician, so he would like
Correct.
to have follow up there. So
Correct.
program does not say you have to be at one place only. It
Correct.
gives you that fluidity that the patient can be
Correct.
seen by an expert and go back to his own pediatrician, and then
Right.
follow-up can happen.
There are, I must remind pediatricians here who are probably trying to dare to treat MDR patient, especially with bedaquiline, that these drugs are extremely toxic. They can have effect on the heart, the QTC interval, etc., in combination with moxiflox, etc. So there is a pre-bedaquiline test which is done, then the bedaquiline is started, and then is repeatedly ECGs are done for QT interval. It's not a simple thing as we think. Sushan, correct me if I am wrong.
Yes.
And then only you can then take over. So I think the initial 1 month, let them be with Dr. Sushant or someone like Dr. Varinder. And then once the patient is stable, everything is okay, no toxicity, maybe you can follow up with
Another
you.
thing, what I want to add is, if somebody wants to treat, they can, but they have to get the basic knowledge. Like how you
Correct.
said bedaquiline, that is one
Mm.
aspect. But if you see
Yes.
the other 4 drugs, even
Yes.
those have their own set of side effects. Like for
Absolutely.
example, cycloserine. For
Yeah,
example, yeah,
lactic acidosis, neuropathies, hepatitis,
with bad neuropathies. Some
neuropsychiatric with cycloserine, and so on and so forth.
all
So I,
things subtle, but and as sir said, if you first get trained, and second have that manual handy with you every time, the
correct,
guidance each other, so that every time the patient comes for follow up, refer to it, and actually do a active monitoring. In
correct,
pediatrics, what we do is an active monitoring. There is
correct,
nothing.
correct, correct.
See,
Correct.
simple thing is, Dr. Nitin, we must follow a shared care model. No,
Correct, perfect.
but they, if you, gradually, it should not stay with few of us. No,
Correct.
it is not another Brahmanism we are talking of.
I
What
agree.
we are talking of is that it is difficult, learn the
Correct.
ropes, and
Correct.
be with someone who, not every
Yes.
patient will have
Correct.
complications. When you see
Yeah.
complications, draw your lines. This one goes to an.
Right.
This one
I
I got
agree.
support.
I completely agree with you. I think that's why more and more people have to get trained and get themselves sort of approved to use these drugs, and it may be easy. I think we have now less time, so let's do some rapid fire. So, first question, Dr. Vijay, if you have an MDR TB and your full DST comes, it shows that one of the first line drugs is sensitive. You will add that?
No, it would all depend on what regime the child is put on.
No,
As you see,
he's
this
put on
group,
MDR regime without the first line. Now
no,
your
but
DST has come.
precisely that is what I'm saying. If we say this, the first line agent like ethambutol, pyrazinamide, they are grouped in group C, in the DRTB regime. And if the child is started on 4 or 5 drugs, and you prefer to use group A and B, and if you are pushed, I mean, these drug, any of the group A, B cannot be used, and you have to use a drug. As per sense, you may add, but otherwise,
Okay.
no.
Correct. So, okay. The second question, Dr. Sushant. Clofazimine not available in private market. Plenty of that by Juventus in the government program. I mean, this is crazy as to why this happens and how can that be held. Same is for, as I said, bedaquiline and delaminate, that they are not available in private market.
So bedaquiline and delamanid, there is a reason why the government has kept the drugs with them. As we know, when it is made available, it is like sab mein bad gaya, and then people will start writing haywire. So that
Correct.
is, and these are very potent and new drugs. So we have
Mhm.
learned from our past experiences that we should not give it a leeway.
Correct.
Clofazimine, yes, we were having a problem. I mean, it is coming and going. I mean, sometimes it goes
Correct.
out of the program,
Mm-hmm.
hospital
Mm-hmm.
not available in private, but that is a part of living here, that we have to deal.
Correct.
Cycloserine goes off. The
Yeah.
only
So
drug I think which has not faced this problem is linezolid, which was
because
but
also used as an antibiotic. Correct.
yeah,
So
yeah.
those who use clofazimine, they should know that the child can really look red. So you should tell them to avoid sun directly because they really look a very red and angry color skin. We already said delaminate youngest age now is 10 kg and above. For
Yes,
bedaquiline is 6 years, so which means 5 years. There are some reports who say you can use it even up to as low as 3 years. Though not in India, but in general in trials, Sushant.
no. So WHO has approved both the drugs to be used in children less than 5 years.
Correct.
It, primarily because they have trials, they have data.
So
It is with our BCG.
why are we not doing that in the NTP still?
So the NTP is a body, but the use of drugs belongs to DCGI. The permission belongs to DCGI. So DCGI is yet to give approval to use bedaquiline for children less than 5 years, pending data from the manufacturer. So they are waiting.
Correct. I think we discussed most of the part of the treatment, including the newer drug and the regime. Something on prevention, because we cannot end anything on TB without prevention. So, role of prophylaxis, Dr. Vijay, whom we will give prophylaxis and which drug and how long?
So household contacts of a patient who is on pulmonary TB, infectious TB, you would rule out active TB. As for
Correct.
symptoms, you rule out
Correct.
active TB and give them TB preventive therapy.
So
Now,
one drug
this
or two
therapy,
drugs?
it is one drug, isoniazid. There
Mhm.
is a regime available of weekly rifampicin and isoniazid, but that is not yet made available widely. It has been used in some districts, I believe,
And how
and
long?
not available. That is given for 12 courses, 3 months.
Correct.
So using
Now,
ionic in this for 6 months. And apart from
correct.
this full contacts, now in the past it was restricted to up to the age of 5 years. Now it is given even
Anyone.
adults. And if possible, what is recommended is do a test to establish infection, like in the form
Right.
of
So you can do an IGRA.
IGRA.
I mean, that's what people, students
Correct,
traveling, they
correct.
do. If they're IGRA positive,
So
they put on INH prophylaxis.
apart from this household contacts in HIV positive
Mhm.
who are treated for TB, after completion of treatment, they should continue to be on TB prophylaxis. Then children who are on immunosuppressant like nephrotic syndrome,
Correct. Malnourished, severely malnourished,
malnutrition,
SAM
leukemic
children.
children,
Mhm.
severe malnutrition, they have to be
All
put
right.
on prophylaxis. Then a newborn who is born to the mother
Yes, mother who is
has drug
open
sensitive
place.
TB,
Correct.
then you would
And suppose the patient is in contact with the drug resistant, you don't give anything and
no, you
see for
need to know
response.
the type of resistance. Now, there is a recommendation if the contact is fluoroquinone sensitive TB, then one could use
Levoflox.
yeah,
Same would apply to a newborn born to a mother. Can you
absolutely.
use Levoflox in such a small child?
Leoflox, I think yes, you can use
Sushant, what are you doing? A mother is open
I'm,
case,
I'm
baby
not
is
too sure.
born, Mdr, Levoflox sensitive in mother. You put the baby on Levoflox, you just
We have just had one case.
no, but you
We,
put them or you don't put them on Levoflox?
no, we had not
No,
put.
just observe. Okay. Dr. Varinder, there is a trial going on of BCG in adults. There were some papers from abroad I read that giving BCG to people up to 17 years and even beyond actually helps to prevent 40 to 50% time reactivation and from infection to go into disease. So, what is the concept of BCG in adults in India?
So this is what the trial is looking at. The data has been, the jury hasn't been in so far on it, because if you look at, go back to the history, we were doing revaccination in our country. Turkey was doing 5 revaccination.
Yes, absolutely.
They,
UAE also, yes.
yeah. So their TB did not come down because of that. Right.
Correct. Correct.
So, but then there is more recent studies which show that there may be some impact on reactivation, and there is also some degree of reinterest in because of the component recombinant BCG vaccines.
Yeah.
So, there is some data to suggest that it may be coming up, but it is still something which is in this trial state.
But what we are using in India in adult is the actual BCG, not the recombinant or
No, it is
the
not the
surrogate.
recombinant. It is
Correct.
the usual BCG, which is
Correct.
being tried, and we would know in about 2 years to 3 years time, because they are looking at after BCG minimum 2 years follow up, and comparing the relapse rate in them versus the others to say
Correct.
whether it has an impact or not. So it will
Correct.
be a couple of years before we will be able to really say
Come
whether
to know.
vaccination has helped or not. And this
Correct.
is also only being done in adults, not in children.
Correct. Perfect. So because lack of time, I will just sum up to say that there are trials with RBCG, recombinant BCG, where the Listeria monocytogenes gene has been replacing the actual BCG gene, so that when the BCG is taken up in the lysosome, it lyses and exposes the antigen to the surface to lead to better immune response. So there are trials going on in adults who had TB in the past to prevent reactivation. There are trials going on in the context of patient with open TB to prevent infection happening in the context. And there is, of course, a trial to replace BCG with recombinant BCG in neonates in Africa. And all these three trials are under the way, and maybe the reports will come to tell us whether RBCG is going to be better than the actual BCG. And as Dr. Varinder said, a subunit vaccine from GSK has been tried in adults who had TB in the past recently to see whether resurgence or a reactivation is prevented. The initial studies showed that there is 50% efficacy in preventing recurrence of TB in such patients. I'm sure there are exciting news for such type of work done to prevent TB, but TB is going to remain with us. And better we get knowledge about how to diagnose and how to treat, especially in pediatric patients where it's difficult to find out as to what is happening. I think it's not going to be easy, and we have to live with it. Before
We'll
I
eliminate it. We will eliminate it.
We will eliminate TB.
But it will not happen tomorrow. It is like
2030
exercise, like just like we started with polio.
2030
Polio was easier.
2030 possible.
Let's give it a push.
Push.
You see,
Okay.
if COVID had not come, we wouldn't have been this bad. That was a setback, and no government could have thought of that. What would happen? So that was a setback. And but then, in all seriousness, if we are not able to, the program is able to take care of its supply lines, which of late are now affected, and drugs and everything is made available. I see a hope. I see a hope.
Correct. So before we end, I will just share my screen again to show something which is very exciting. Please pardon me. I hope you're able to see my screen. Everyone can see it. So we had the first Gujarat Pediatrician WhatsApp group meeting in the March, and we are very happy to say that that's archived on the Gujarat Pediatrician YouTube channel, and more than 1,200 people have actually viewed it. Beyond that, 200 to 300 who viewed it on live on that day. And just last week, we had this first part of TB diagnosis, and we are very happy to say that already 600 plus more people have viewed it online on the YouTube channel. And I'm sure many more would have attended it today. And today's talk also will be archived by tomorrow on the same YouTube channel. So please subscribe to this Gujarat Pediatrician YouTube channel so that you can see the, and this all this program will remain at least for 6 months on YouTube for you to view it again and again and pass on the message to your friends. And before I sign off and conclude today's talk and leave it to Dr. Bajania to give vote of thanks, I want to tell you what's going to happen next month. So on 9th of May, that is the second Thursday of May, same 9 p.m. to 10:30 p.m., we are going to look at joint, which is looking very angry. So we are having something on the rheumatology. I won't tell you the details and the faculty because that will come in the form of flyer very soon. So please mark your date 9th May, and we will have yet another exciting session on joint is angry. Over to you, Dr. Ramesh, to conclude today's session.
Yes. Thank you, Nitin Bhai, for master blaster like batting. I thank profusely all the three faculties, Dr. Varinder sir, Dr. Vijay Evle sir, Dr. Sushant Mane, for giving due justice to this vast topic of pulmonary tuberculosis. Of course, we had to extend it in 2 sessions, but it was fair and necessary. So my heartfelt gratitude to all of you three. My sincere thanks to Zydus people for extending this logistics help. And thank you all the viewers for appreciating our webinar by viewing it in large number. Please keep showering your love and blessings, and we'll meet on 9th May with this pediatric rheumatology topic. Thank you so much. Good night. Thank you so much.
Good night, everyone. Good night. Good night. Good night.